Kumar.
Okay.
Dear delegates, I am here to present my research report on the efficacy of segmental stabilization exercises in the subcategories of the lumbar segmental instability, a randomized, double-blind, placebo-controlled and crossover study. I am from Kolkata Medical College, Mangalore, Manipal Group. Next slide. I greatly acknowledge the support rendered by my HOD and my dear colleagues. Background: mechanical low back pain has been identified as the largest cause for a patient visiting the physical therapist, and the prognosis of low back pain is earlier in the acute stages is better, but as it goes chronic, it goes for more disability, and increasingly the segmental instability is being identified recently because of the poor prognosis of the chronic low back pain. And there have been various authors who described about segmental instability, right from Punjabi and White to Julie Fritz, and they categorize the types of segmental instability initially as mechanical instability and functional instability, two categories. Mechanical instability is of end range instabilities, whereas the functional instability is the neutral zone, increased neutral zone instabilities. And management of segmental instability was directed more towards the core stabilizers, that is the transverse abdominis, which is the global stabilizers, combined with the local stabilizers of multifidus. And mechanical instabilities were managed either surgically or with the braces. Recently, there have been patterns of segmental instability which were identified, which were mechanism-based, which was described by Peter O'Sullivan. He described about flexion pattern, extension pattern, lateral shift pattern, and multidirectional pattern, 4 patterns for segmental instability. And he also categorized the impairments into movement impairments and motor control impairments. Movement impairments are the ones which are the end range instabilities, actually it fits, and the motor control impairments are for these patterns of the segmental instability, that is the lack of muscle control during a flexion, or the lack of muscle control during the extension, or the lateral shift, or the multidirectional patterns. Purpose of our study was to study the effectiveness of mechanism-based multifidus strengthening segmental stabilization exercise versus the placebo intervention in lumbar segmental instability subjects. And we hypothesized that the segmental stabilization exercise would be better than the placebo in the 4 subcategories of the lumbar segmental instability. The design was a randomized, double-blind, and the placebo-controlled and crossover study. Study setting was our outpatient department. Study duration was 2 months. Testers: 1, the postgraduate assistant professor, myself, and the independent and blinded observer who was a qualified physiotherapist for measuring the outcome. He was blinded. The instruments that were used was the Autistic Disability Index questionnaire for categorizing the subject's initial screening to categorize the disability of the subject, and we took only the mild to moderate disability patients who will respond to the conservative interventions. A 10 cm visual analog scale, 0 to 10, 0 no pain, 10 maximum pain possible. Pressure algometer for measuring the pressure pain thresholds, and then the joint plane grading scale is a clinical scale which is manually examining the passive accessory intervertebral mobility of the spine using the central post-arterial pressure, and the examiner grades from 0 to 6, where 3 is normal and 0 is ankylosed and 6 is unstable. Subjects: they were blinded from the study design. There were 18 subjects, 12 men and 6 women. They were 18 to 36 years of age. And inclusion criteria we chose was the Delphi checklist. It was found out from the recent multi-center survey which was done in the American states that there were some descriptors of lumbar segmental instability. There was a consistent agreement between all the therapists, and they found that there were some subjective descriptors, that is the symptoms which the patient complains, and objective descriptors which are the clinical signs which the therapist detects. And out of those 13 criteria, 13 points on the subjective, at least we preferred at least 7 should be positive for a proper diagnosis of segmental instability. And we chose only the single level instability patients. And we also tested what is called as the prone segmental instability test, where we check the accessory mobility in the presence of contraction and in the absence of the contraction of the extensors. So in presence of contraction, if the mobility is reduced, it means an active control or the muscles being weak, that is caused as the segmental stability. And also the disability index for less than 40% of the disability. We excluded subjects who had inability to understand or cooperate during the study. The procedure, the chart shows the subject. Once the consent is taken, evaluation was done. Evaluation was done for the diagnosis of the pattern of the instability, and then we found out whether they are flexion pattern or extension pattern or lateral shift pattern or multilateral pattern. Then each of the pattern was randomly, then they were randomized. The subject was randomized to the intervention, either the placebo or the segmental stabilization exercises. The subject was given the first intervention in the group 1 or the group 2. They were randomized depending on the order of the intervention, because we chose crossover design, and the group 1 involved the control intervention first and the second followed by the experimental. The group 2 involved the experimental first and then the control. So same subject was given both the interventions, and then the outcomes were measured at pre and post of each intervention. Prone segmental instability test, we gave central position under pressure without contraction of the extensors, and then with the contraction when the patient is putting his effort to lift the leg. Pressure point threshold assessment at the level that is directed as a systematic during the manual examination. We chose single level so that we can take the accurate PPT value. Treatment procedure. Placebo intervention included supervised comfort directed prone lying. For example, the patient may be comfort to lie neutral prone or with a pillow under the abdomen, whichever they preferred. And the therapist was present with the patient, and communication was happening between the therapist and the patient. Experimental intervention included flexion stabilization exercises, that is the multiple strengthening given in the lordosis being flat in the quadruped position. And extension instability they are given with the presence of the lordosis in the quadruped position, that is the extension stabilization exercises. Lateral shift instability patients had visible lateral shift when you see in the neutral postural examination. So they were given lateral shift correction first and then given neutral position of stabilization exercises. Multilateral instability patients are given multiple strengthening in extended position, that is with the lordosis, then neutral lordosis, then flattened lordosis in the quadruped position. You can see that the flexion instability subject had a pattern of hypolordosis, a reduced lumbar lordosis. So they were given, the instability was in flexion, so we gave the stabilization exercise also in the flexion position. Flexion instability is expected to be the most commonest of the patterns. Extension instability pattern, they had a hyperlordosis, the spine was unstable in the extension, so we gave the multiple strengthening with the lordosis in the extended position. Here, during the quadruped position, the patient was instructed to tuck the chin, and then instructed to also do hollow the abdomen, and then to get the middle range, the neutral range of the desired position, flexion or the extension position of the spine. And once the position is achieved, the cervical retraction maintained, the hollowing is maintained. And then once the level of T11, T12, where the multiplicator starts acting, then the therapist palpates manually to check whether segmentally, at the affected segment, there is activation of multiplicator or not. If there is no activation, then the therapist applied a vertical digital pressure to facilitate a quick stretch to promote the contraction. Once the activation comes at that level, then the patient was instructed to lift only till that level. So that selectively at that segment, multiplicator could be strengthened. It's as per the earlier studies. Lateral shift instability patterns are given lateral shift correction, and then the stabilization exercise with the neutral lumbar lordosis. Treatment duration was 15 minutes for both the interventions. It was given on 2 different days, and they were randomized into the group 1 or group 2 for the order of interventions by block randomization. Group 1 received the placebo and then the experimental. Group 2 received the experimental and then the placebo. The 3 outcomes are collected by the blinded observer 4 times, that is pre and post for each intervention. Analysis was done using repeated measures analysis of variance, 95% confidence interval using SPSS. And we saw in the results that the visual analog scale, the joint leg bearing scale, and the pressure point thresholds have showed difference.
It's not here. So there's no.
Yeah, okay. Virtual audio goes. Okay, and then sorry for the description. And then you see that the significance is present in the second phase. That is, the first 2 blocks show the control period, whereas the next 2 blocks shows the experimental period. And you can see the difference was greater in the experimental period. Extension pattern also showed significant differences, but not in the pressure point threshold. Lateral slip showed mixed responses. Multidirectional pattern did not improve in any of the patterns. And we saw that our null hypothesis for the extension, multidirectional, and lateral shift patterns were actually accepted, and the subgroups behave differently. So when we do segmental instability studies, we should try to group them together into a similar pattern so that we'll get a better response. Our internal validity was enhanced because of the blinding, but there was no concealed allocation. External validity is enhanced because the between subject differences were not there, because we use single subject as a crossover design. And we have our own limitations, that is the lack of sample size being small, and the subgroups actually should have been more followed up longer period of time or longer interventions. We had only one sitting of treatment. Further studies is definitely possible with further modifications. I conclude that flexion and stabilization exercises is effective in the flexion pattern of lumbar intersegmental instabilities, but the other patterns, however, warrant further studies on more appropriate methods of management. I thank these authors for their wonderful references, and I thank all of you for being such a patient crowd and giving me such a valuable opportunity. I thank the scientific committee of IAP 45th Annual Conference. Thank you so much.
Question.
You said you applied for the activation of multifiders. What was exact manual? What you told your patient to activate multifiders with any particular position? I want to know.
Because this method has to be standardized, there have been authors like Guadal and Jules and Julie Fritz. They use the pressure biofeedback. Traditionally, what is done, even now it's practiced, is they use the pressure biofeedback in patients in group lines to standardize that the pressure. Patient should not substitute it with the longer or the rectus abdominis. So this difference in the pressure should be maintained constant. It should not exceed beyond 5 to 10 millimeters of mercury. If it exceeds beyond that, it's a substitution by the long abdominis. But we did not use the pressure biofeedback. In the quadruped position, there are other group of authors who have done from the USA. The authors from America, they have done studies using the quadruped position, emphasizing on you try to achieve the maximum lordosis flattened position, and then try to get the lordosis which is maximum arched position. Okay, like a cat and camel. You do both the ranges, and then give 2 in favor of flexion and 1 in favor of extension, and achieve the neutral. Once you achieve the neutral, as the patient subject to retract the chin and then hollow the abdomen, and then at that position instruct the patient to breathe normally. Some patients may have difficulty in breathing in this position. Those patients have to be trained first for attaining this position and then go for the training of this exercise.
Yes, sir. Then my next doubt is that how you confirm that particular position is neutral for that particular patient, because neutral position differs from patient to patient. It is not exactly in between flexion and extension. And my next question is that you ask them to do abdominal hollowing maneuver. Now there are certain studies, one of the studies I will quote for you, that there is a technique for lumbar stabilization done in 1995 March Science of Physical Therapy, that whenever you do abdominal hollowing maneuver, there is automatic activation of multifiders, and you cannot contribute all these effects of your study only to the sole strengthening of multifiders. As soon as you go for the abdominal hollowing, you automatically activate multifiders. And to activate multifiders, what you have to do, it is a local stabilizer. Transversus is also a local stabilizer. Multifiders you have to activate through the local feedback, by giving them local feedback on the spinal process. And whenever you are doing abdominal hollowing, this is the activation of the local stabilizer around, basically transversus abdominis first, internal optics, and your multifiders. So specific activation of multifiders. How you contribute this effect of specific activation of multifiders?
What I am interested now is to clarify one point. Transversus abdominis is still a global stabilizer only. I think globally it is accepted. But multifidus is a segmental stabilizer and local stabilizer. And when you do the hollowing of the abdomen, transversus abdominis definitely acts. Multifidus will not act unless you instruct the patient to maintain the lordosis. You can hollow the abdomen in any position, be it in extension or be it in flexion. Transversus abdominis can act. But only when you tell the person to maintain the lordosis and do an activity, then the multifidus comes into action.
one sec. Are there any other questions? All right, go ahead.
So the question was flexion dysfunction and extension dysfunction. They are totally different categories according to McKenzie, which is hypo. Okay. You want me on what basis I have diagnosed them as flexion instabilities, extension instabilities?
To activate multifilers. Now you have to take your patient who.
Action, I have never told that lordosis is important for maintaining for the multipiters. Whatever position the spine is, whatever the lordosis is, you might train the patient to maintain the lordosis in flexion also, or in extension also, or in neutral also. Any position, the curvature of the spine should be maintained. That segmentally is maintained by the multipiters. Lordosis, neutral lordosis is different. Lordosis being flat is different. Lordosis being hyperlordosis is different.
Right. Excuse me. I think we will continue on. Very interesting discussion. We will continue it outside. Thank you, Dr. Kumar. Appreciate your presentation to take the next agenda.
Thank you. Thank you so much.
Thank you, sir.
The next speaker is Dr. Soma Majumdar, and the title is A Clinical Trial Research on Patients with Stable